Thanks, Elsa. I'll pay you later for that introduction. So as Elsa says, I'm the new Stop Smoking Systems Strategic Manager across Fresh. And I've been in post for just over 2 months now, and it's really great to be back in the Northeast and linking with all of the amazing people who work there. And I just, echo in some of the sentiments that we've heard this morning. We are doing a really great job in the Northeast. We often are leading the way across the country. But, I think one of the things I'm really kind of passionate about is how we're always looking to do better. We're always looking to go to the next step because we recognise, how important this is. So, I just wanted to start, though, with a little bit of a reflection as to what is the norm. And all of these things used to be the norm, from smoking in pubs and clubs, any enclosed spaces, up until 2007. We had smoking in aeroplanes until the 1990s. We had legislation just, 9 years ago to ban smoking in cars with children. Up until 8 years ago, it was normal to see these bright-coloured, shiny packs of cigarettes. They were winking at us from behind the corner shop whenever we went in to buy our morning papers. It was normal to see advertising at sports events, and every single pub had a vending machine in the corner that sold very expensive small packets of cigarettes that as an adult you probably would never have used. But I know from my own experience as a teenager, that was an ideal way. So we've come a long way. These adverts here, we don't see these anymore, but these are some of my favourite when I look at some of the old vintage adverts, and it's kind of things like, "Gee, Mum, before you scold me, you better light up a Marlboro and calm down." This was normal. And we look at this now, and it's hard to believe that actually this was normal until it's not normal. And we have come a long way. We've got generations who have never seen these types of adverts. We've got 18-year-olds who have no idea what it would be like to go into a pub or go into a restaurant and come home smelling of smoke. And none of these changes would have been made if it hadn't have been about kind of advocacy, change in legislation, and change in the norm. And even within healthcare, smoking was normal. From classic vintage adverts targeting doctors, we know more doctors smoke Camels than anything else, to actually smoking in hospitals, and that's both patients and staff. There used to be cigarette girls that came around to the bedside selling cigarettes to patients. More recently, it was normal to see people smoking outside hospital entrances. It was normal to have smoking shelters within the grounds. When I first started my career, a number of years ago, within mental health services, it was normal that you actually took a patient and you had a cigarette with a patient in order to build up rapport. We wouldn't dream of doing that now, or I hope we wouldn't dream of doing that now. So as I say, it's true that we've come a long way, and what was normal has changed over time. But we need to continue, and culture change. We recognise that this is one of the biggest levers that we have to actually reduce smoking prevalence and reduce the harm from smoking. And I know we've seen this slide, but we can't assume that the job is done. We still have over 5.6 million people in England smoking. More than 1 out of 2 will die from a long-term condition related to smoking. We know it's still the leading cause of death and disability. 75,000 people dying every single year. And I could share a load of statistics on smoking-related death and disease, on how life expectancy is declining in the country, how healthy life expectancy is still declining, and people are living nearly a quarter of their lives in poor health, and that tobacco is the leading cause of that, driving it forward. But I do think ultimately it comes down to this. Elsa had pointed out her father. I know Sue's father's on there. My father's the one in the bottom right there who died of lung cancer at the age of 50. And I'm sure every single person in this room will know somebody who's not only died of a smoking-related disease, but has lived and suffered from a smoking-related disease. And it impacted not just their health, but it impacted their wider life, their family, their work, everything. I also want to say we've probably all heard the rhetoric of lifestyle choice. I know it's been very topical in some of the debates that have been happening on the media and in Parliament, but no one chooses to be a lifelong smoker. No one chooses to live more of their life in poor health and die earlier. And this is why it's really, really important that within the NHS that we acknowledge tobacco dependency as a long-term chronic relapsing condition, and that we treat it in the same way that we would treat any other long-term chronic relapsing condition, with evidence-based treatment. And that we strive to normalise and support smoke-free admissions in hospital, and across the wider system, that we strive to normalise quitting and provide an equitable treatment, access to treatment. So I've mentioned the culture change and the legislation and how that's changed over the years. But we've also in this period seen a lot of changes within the world of smoking cessation. From where we started maybe 25 years ago at the creation of stop smoking services in the community, we've seen the introduction of new medications, we've seen the introduction of new service standards, new quality standards, guidance. We've seen the development of these opt-out treatment pathways, of our tobacco dependency treatment services within the NHS. And we've seen services embrace vaping as a tool for adults to quit smoking. Over this time, our smoking rates have reduced. If we think back to the 1970s, 1 in 2 adults smoked. We're now down to, nationally, 11.6%, but in the North East it's even lower, 11% of the adults smoking. But as smoking rates have reduced, so too have the number of people who are accessing support to stop smoking. And despite the overall reductions, we still have pockets and cohorts where smoking prevalence is significantly higher. And more often than not, these are in our most deprived areas, our most deprived communities, disadvantaged. So people, as I say, living in deprived areas, people with multiple long-term conditions, those with mental health conditions, and those with drug and alcohol or who are homeless. Looking at the projected prevalence, England is actually on course to miss that 6% ambition by 2030, sorry, the 5% ambition by 2030 by around about 9 years. But for those people in the most deprived areas, we're actually on course to miss it by 20 years, and that's only going to exacerbate those existing health inequalities. But what I want to do is give a message of hope. We shouldn't be disheartened, as it is possible to change that trajectory and still achieve less than 5% smoking prevalence in the next 5 to 6 years' time. Now, some of you may recognise this. This is some modelling that UCL did for us last year at the conference that we ran. To get to that 5% prevalence, we need just over a 1% reduction per year. And to achieve that, we need to have 46% of all smokers in the North East making a quit attempt every single year. And that's up from where it's currently at around about 37%. We also need to increase the overall quit rate to around about 29%. To put it into context, that would be about 120,000 people in the North East making a quit attempt every year. It may seem ambitious, but what I want to kind of do is explain that this rate of decline, it's something that we have done before. So if we look here, we can see that the trajectory in the North East from 2012 to 2017 was at that level. And actually, we can start to see that trajectory again from 2020. So this is how we've done it. And you've seen Rachel shared this slide. This is our vision for the smoke-free, the North East system-wide approach to smoke-free. And it puts that person who smokes right at the heart and encourages everyone to make at least one significant quit attempt per year. It's where discussing tobacco dependency is every healthcare professional's responsibility, and that people can choose how and where they access support to quit. It recognises the specialist roles that our local authority stop smoking services, our NHS tobacco dependency treatment services, have to play in providing both universal and targeted support. But it also acknowledges the role of the wider workforce. So, for example, primary care, and when I say primary care, I mean the wider definition of primary care, in relation to delivering very brief advice plus, in order to prompt quit attempts. This system-wide approach acknowledges the full spectrum of support that's required in order to meet everybody's needs. So whilst we aim to increase the number of people who go into our stop smoking services in the community and our NHS tobacco dependency treatment services, actually 120,000, we don't have the capacity in services to meet that. And not everybody will want or need to have that level of support. We recognise that a proportion of people will continue to quit unaided, whether that be cold turkey, buying over the counter, buying vapes, whether it be using self-help tools, online resources, apps, for example, NHS help groups on Facebook. And all of this is supported by the fresh mass media quit campaigns, the digital and online resources that we have as a system, a workforce plan, and, as I say, the wider tobacco control work. Everyone across the system, we all have a key role to play. And I think, that for me, this is the key thing. We are all the system. When we talk about a system-wide approach, we are all the system. It doesn't matter if we're a tobacco dependency advisor, a stop smoking advisor, whether we work as a clinician, whether we work in public health, in local authority, whether we're in a communications team, a trade and standards team. We are all part of the system, which puts that person who smokes at the centre. And I'm going to speed up because I've got my warning sign. So, how does this work in practice? Well, there's a shared vision and a continued focus. We need to continue to prioritise tobacco, supporting people to quit, and that wider tobacco control work. And that does require that strong leadership from across the system in order to maximise the system-wide contribution to supporting people to quit smoking. It recognises that both individual level and population level interventions have a key role to play. We know what works. We don't have to reinvent the wheel. It's about consistently applying an evidence-based, multifaceted approach, building upon the key drivers that we've heard about, such as the Core 20+5. We also have the upcoming tobacco and vapes bill. Again, another key driver. There's acknowledgement of the disparities and a recognition that resources do need to be targeted to enable an equitable provision for people who are from the smoking populations with the highest need. And this means building flexibility into the system so that there's more intensive or longer lasting support for those who need it. So, for example, people with SMI or people who maybe are homeless. It's about creating an environment where it's normalises that making that quit attempt and recognising that treating tobacco dependency is everybody's responsibility, not just the responsibility of the NHS, not just responsibility of public health over there in the corner. Our approach needs to be system-wide, it needs to be sustainable, and it needs to be embedded. We can take it year by year, but we need to be realistic and we need to have a 5 to 10 year goal where it's clear what our goal is so we don't become distracted and that we can review it as we progress. I've just kind of wanted to reflect on reinforce the culture change. And I mean, I'm not going to read this out, but this was from the Smokefree NHS survey that Ash undertook. And basically what it recognised was that the culture change of treating tobacco dependency as a long-term chronic relapsing condition was one of the biggest enablers that we had. And at the same time, one of the challenges was resistance to that culture change. And again, unfortunately, workforce uncertainty is a barrier to that culture change. And we know, you'll all know some of the kind of barriers that we've had. But the key thing to take away is that 57% of all tobacco dependency advisors report that they really do enjoy their work all of the time. I'm nearly finished. So, I mentioned that we have the tobacco dependency bill. It's great, but I just want to kind of say this is not job done, you know. I've taken some slides here from the smoking toolkit, and I'd really recommend anyone to have a look at it. But this just shows that variation in smoking rates that I talked about. And we can see that, you know, actually, we know that there is huge disparity there. So we can't just assume that it is job done and the tobacco and vapes bill is going to end there. We need to keep this as a priority. And I suppose, you know, as I said, we're all the system, and I want you to think about that 5% by 2030 ambition. Is that really our system's end game? 5% across the northeast is over 100,000 people still smoking. Now, bearing in mind that image that we saw earlier on, is that what we want, or can we be more ambitious? Can we see the end of smoking in our lifetime so it becomes a thing of the past, a bit like, you know, the rotary phone or the dial-up internet? Just one final point. When I was pulling this slide deck together, my 18-year-old daughter kind of was being really nosy and said, "Mum, why are you putting in a sound effect from Doctor Who to your presentation?" Now, it did make me feel really, really old, but what it did is it gave me hope. Hope that in the future, actually, the next generation might not know what smoking is, might not know what cigarettes is, in the same way that she had never heard that. Thank you.